Today's video will cover meningitis. So the definition of meningitis is that it is the inflammation of pia arachnoid and the fluid contained in them. Other name. So the other name of meningitis is cerebrospinal fever. Now we'll discuss the types of meningitis. First of all, we classify them into infective and non-infective. In infective, we further have acute, chronic, and subacute. Acute further is caused by bacteria, fungi, and viruses. Now, meningitis can also spread through hematogenous route. Also, it can spread by direct extension of infection from infected surface structures. Example, paranasal sinus, skull bones, ears. Then coming on to the very important part, that is bacterial meningitis. Now bacterial meningitis is caused by a number of bacteria and it is acute purulent infection of subarachnoid space, acute purulent infection of subarachnoid space. To remember the causative agents, first of all, in neonates, we see that we'll remember an acronym LKG. So for L stands for Listeria monocytogenes, then K for Klebsiella, then gram positive bacteria and gram negative bacteria. In gram positive we have group B streptococci, and in gram negative we have E. coli and Bacillus proteus. Now for the children in old age and immunocompromised patients, we will remember the mnemonic as man's leg. So Mycobacterium tuberculosis, Neisseria meningitis, then Streptococcus pneumoniae, then Listeria monocytogenes, E. coli, for C we have Cryptococcus neoformans, and we also have Haemophilus influenza. Now for the adolescents or the adults, we have M. tuberculosis, Neisseria meningitis, meningococcal meningitis, Okay. Now coming on to the pathophysiology or the pathogenesis of meningitis. So in pathophysiology of meningitis, we will see that first the bacteria, they will invade the sympathetic autonomic system, then they'll multiply and cause lysis of organisms. The antibodies will cause lysis of organisms. Thus, there will be release of bacterial cell wall components, that is the endotoxins and teichoic acid. Now, this will lead to the production of cytokines. Now, this will lead to four things. First of all, is altered blood brain barrier permeability. Second one is that there will be adherence of the leukocytes to the endothelial cell wall, to the endothelial cell wall. There will be altered blood flow. Also, there will be the more production of excitatory amino acids, nitrous oxide, and reactive oxygen species and nitrogen species. Okay, now in altered blood brain permeability, what we'll see vasogenic edema, and we'll also see that the increase in the permeability of blood vessels with leakage of plasma proteins into CSF. Now, the adherence will lead to the leukocytes. They'll migrate into the CSF and degranulate. As a result, they'll release toxic metabolites. Now, the exudates in CSF, they will obstruct the outflow, cause resorption of fluid. Now, this will lead to obstructive and communicating type of hydrocephalus. Cerebral ischemia. Now, in altered blood flow, either it will decrease or it will increase. It will be accompanied by this. Then, this is going to have a cytotoxic effect. All of them will lead to cell death. All of them combined, they will lead to decrease in the consciousness and increase in the intracranial pressure, ultimately leading to coma. Now, this was the pathophysiology of meningitis. Now, coming on to the symptoms. In symptoms, what we get to see is, we see that there is phonophobia, then there is blurring of vision, also nausea and vomiting. There is decreased mental awareness, lack of consciousness, confusion. In signs, we'll see that there is neck rigidity, head rigidity, then we have papilloedema, positive Brudzinski's sign. We can have cranial nerve palsies. We will have positive Kernig's sign. To remember this, you can remember chunk BP. C stands for cranial nerve. Head. We in head we have head retraction, and then we have neck rigidity, then Kernick sign, then Brudzinski sign, and then papilledema. Now signs and symptoms we have done. Now we'll do the investigation. In investigation, we'll culture the blood and CSF. In CSF, we'll see that there will be a rise in protein content and decrease in the glucose content. Then the aminase enzyme also might be present. Then we'll even do the CT scan and we'll see there's hydrocephalus. For a fact, we'll do chest X-ray and we'll see that patchy opacifications. Then we will also do MRI with gadolinium. Then coming on to the treatment. For treatment, we give a antibiotic cover. So in treatment for pneumococci and meningococci, we will give penicillin 20 million units, and we can give ceftriaxone, which is cephalosporin. In this will be given in 4 to 6 doses each day, and this will can be given as 1 to 2 grams. Then for Haemophilus influenzae, we will give amoxicillin or ampicillin 300 to 400 milligram per kg IV per day. This is for children. Plus we'll give chloramphenicol 200 milligram per kg IV. For adults, we'll give amoxicillin 12 to 18 grams daily, chloramphenicol 6 to 8 grams daily, plus ceftriaxone 2 gram to hourly, 12 hourly. Also, for combination, we can give the three. For an unknown etiology, we'll give as well as the vancomycin along with it. Then it has been seen that corticosteroids are being used as intrathecal injections. For prophylaxis, we will give rifampicin in adults 600 milligram, and this is it.